Hello everyone. So in today's pathology class, we'll be discussing endocrine pathology. The topic we'll be discussing is of thyroid gland. So before we start the pathology, what is your thyroid gland? Yes. So thyroid gland is an endocrine gland. It is the largest endocrine gland in the body. Its location is in the neck region, opposite to the C5, C6, C7, and T1 vertebrae. Alright, it is responsible for secretion of your T3 and T4 hormones. Alright, so now coming to its pathology, we will be starting with the inflammatory conditions. We'll be starting with your thyroiditis. Alright, so what is thyroiditis? So we know thyroiditis is the inflammation of the thyroid gland. Alright, now we can classify this thyroiditis based on two things actually, based on the onset and your duration. So based on the onset and duration, thyroiditis can be classified into three groups. All right, first one being acute, second being subacute, and third being your chronic. So under acute, acute thyroiditis could be due to your bacterial infections, most common of which are staph and streptococcus. Then there's your fungal infections. Most common cause is your aspergillus. Thirdly, any radiational injury. All right. So now coming to subacute, it could be your subacute granulomatous thyroiditis or subacute lymphocytic thyroiditis. Now, in chronic, there's your Hashimoto's thyroiditis. All right. Now, Hashimoto's is an important topic and we'll be discussing it further. So, what is Hashimoto's thyroiditis? Now, this is an autoimmune condition. It is an autoimmune disorder. It is also known as autoimmune chronic lymphocyte. All right. Now, this condition is more common in women than in men. All right. More common in your middle-aged women, to be more specific. Now we'll be coming to its etiopathogenesis. All right. So before getting to etiopathogenesis, there are few conditions that can lead to this. So we'll start with your genetic conditions. Genetic predispositions. They can be polymorphism of any of these three genes: CTLA4, PTPN22, and IL2RA. All right. Polymorphism of any of these genes with some certain or any environmental factor. All right, environmental factor, which will lead to alteration in self-tolerance. Now, this alteration in self-tolerance leads to increase in your T cells. All right. So, two types of T cells. Those are your CD8 and your CD4. So, there's an increase in your CD8. There's an increase in your CD4. So, now we'll first discuss about your CD4. So, CD4 plus your macrophages leads to increase in your interleukins plus, that is, and your inflammatory cells. All right, which leads to destruction of the thyroid gland. All right, and CD8 cells, which are cytotoxic, so there is direct cytotoxicity. All right, so now we have three factors. One, that is the destruction of thyroid gland. There is CD8 contributing to your direct cytotoxicity, and also the environmental factor from here. So these three factors lead to production of your autoantibodies against TPO, that is your thyroperoxidase. So these three factors lead to autoantibodies against TPO, thyroperoxidase. All right, so this is the etiopathogenesis of your Hashimoto's. We discussed that there were some genetic predispositions. There was your CTLA4, PTPN22, IL2RA. There were polymorphism of these genes plus some certain environmental factor contributing to this polymorphism, leading to the alteration in one's self-tolerance. This led to an increase in your T cells. CDT led to direct cytotoxicity. CD4 along with your macrophages led to increase in interleukins and the inflammatory cells. This caused destruction of thyroid gland. So there were three factors which contributed to your autoantibodies against TPO. All right, so that was the etiopathogenesis. Now coming to the symptomatology of an individual suffering from your Hashimoto's. All right, now this is an interesting concept. I would like you to pay attention. So what happens is there is initial hyperthyroidism. All right, there is initial hyperthyroidism. This is known as Hashimoto's thyrotoxicosis. All right, now this initial hyperthyroidism is a transient phase. All right, it is transient, it doesn't last for long. So eventually it leads to a permanent state of hypothyroidism. All right, so initially there was hyperthyroidism, but it was a transient state. It is known as Hashimoto's thyrotoxis. Eventually it led to permanent hypothyroidism. All right, now coming to its diagnosis. All right, serology, we can see there are anti-TPO. All right, which we saw in the etiopathogenesis. We also see that there is decreased in your serum T3 and T4. All right, there was decrease in serum and T3 and T4. We know this because of the permanent hypothyroid state, and also RAIU is decreased. What is this RAIU? This is your radioactive iodine uptake. All right, so this is also decreased. Now, coming to the clinical features, we see there is a painless, firm, moderate, goitrous enlargement of the thyroid gland. All right, now Now we're going to come to the most important aspect of pathology, that is the morphological features. So under morphological features, we are concerned with two things. Yes, that is the gross and the microscopic features. All right. So coming to the gross features of a thyroid gland in Hashimoto's, we see that the thyroid gland is lobular. All right. We see there is a rubbery texture to it, and we see that it is firm and enlarged. So when we're seeing it's enlarged, how enlarged is it? It is around 100, it weighs around 100 to 300 grams. All right, so now we're going to discuss the microscopic features. So what do we see here first? We see there is decrease in the lymphoid cells. There is increase in lymphoid cells. We see a lymphoid cell infiltration, right? We also see, look at the lobular septa here, all right? All right, here. So what are we seeing here? We're seeing that the fibrous septa, there is thickening of the fibrous septa. All right, this is fibrosis. All right, and we see the follicles. All right, we see the follicles, atrophy of the follicles. Atrophy of the follicles. All right, and we see something here. What is this? These are Hurtle cells. All right, what are these Hurtle cells? Now this is something that's very important. We have to know what are Hurtle cells. Hurtle cells are also known as, I'll be writing it here, they're also known as Ashkenazi cells. All right, they're an example of your oncocytic metaplasia. All right, now what are they? What are the Hurtle cells basically? So these are nothing but your follicular epithelial cells, all right, which are transformed into their degenerated state. All right, so that's what Hurtle cells are. They're nothing but the follicular epithelial cells which have been transformed into their degenerative state. All right, the last heading we'll be discussing in Hashimoto's is the complications. So what are the complications? The complications is neoplastic transformation. All right, it could transform either into your maltoma or carcinoma. All right, so with that done, we are done with your Hashimoto's. All right, now the next topic we'll be going to is your Graves' disease. All right, so what is Graves' disease? Graves' disease 2 is an autoimmune disorder. More common in women, okay, usually occurring in the age group of 30 to 40 years old. All right, now Graves' disease has a triad of features, a characteristic triad of features. Number one being hyperthyroidism. All right, number two is diffused thyroid involvement, and three is ophthalmolopathy. All right, so these are characteristic triad of features of a person having Graves' disease. All right, it's an autoimmune disorder, more common in women, usually occurring in the age group of 30 to 40 years old. The characteristic triad of features were hyperthyroidism, diffuse thyroid involvement, and ophthalmopathy. All right, now we'll be going to the etiopathogenesis. For your Graves' disease, the first topic we'll be discussing under this is your genetic predispositions. Right, again, polymorphism of any of these three genes, CTLA4, PTPN22, IL2RA, with certain environmental factors. Usually any form of radiation. All right, also association with any autoimmune disease. Now, this is because Graves' disease may be found in association with some other autoimmune disease, example, your Hashimoto's. All right. Now, there are some other factors. For example, the sex, that is more common in women, smoking, and emotional stress. The fourth one, auto antibodies. All right. Now, this is an interesting topic. Autoreacting lymphocytes increase your TSI. Yeah. So these TSI go and bind to the receptors of your TSH. All right. And they cause increase in your T3 and T4. All right. So these autoreacting lymphocytes increase TSI, which binds to the receptors of your TSS, thyroid stimulating hormone, and stimulates it to release T3 and T4. So this was the etiopathogenesis for your Graves' disease. Now we'll be coming to the clinical features of Graves' disease. All right. So we know that there was a characteristic triad of features. All right. One being hyperthyroidism. Two was your diffuse thyroid involvement. Right. And three of ophthalmopathy. All right. So now, diffuse thyroid involvement. This was your thyroid enlargement. All right. Now coming to ophthalmopathy. These are the features we see. We see lid lag. We see upper lid retraction. All right. We also see weakness of the eye muscles and proptosis. All right. So these are the things we see under the ophthalmopathy heading. Okay, these were the ocular abnormalities. Few other features we see are, so this was 1, 2, 3. Few other features we see are dermatopathy, right? Tremors and nervousness. All right. Now let's come to the most important part of pathology, the morphological features. All right. So the morphological features, we'll start with the gross features of the thyroid gland in Graves' disease. 1, there is enlargement of the thyroid gland. Now, in this condition, the thyroid gland weighs around 70 to 90 grams. All right. And it also loses its normal translucency. All right. Now, coming to the microscopic features. So in the microscopic features of Graves' disease, we see these following things. All right, we see papillary infoldings. Yes, papillary infoldings. As you can see here, the papilla is infolding. All right, infoldings of the papilla. We also see epithelial hyperplasia. Yeah, hyperplasia of the epithelium. All right, we also see the follicles are deficient in collide deficient follicles. All right, so these were the histological features of your Graves' disease. All right, so the next topic we'll be starting with is goiter. So what is goiter? Goiter is basically enlargement of the thyroid gland. All right, now this enlargement of thyroid gland is caused by two things. All right, compensatory hyperplasia and hypertrophy of the follicular epithelium of thyroid gland. All right, so goiter is nothing but the enlargement of thyroid gland, which is caused by the compensatory hyperplasia and hypertrophy of the follicular epithelium of thyroid gland. This occurs in response to thyroid hormone deficiency. All right, now, so by this we know that the etiology would be deficiency of thyroid hormones. It couldn't be either due to lack of iodine or goitrogens. Now, what are goitrogens? All right, goitrogens are nothing but substances that interfere with the synthesis of thyroid hormone. So goitrogens are substances that interfere with thyroid hormone synthesis. All right, an example of which could be drugs which are used in the treatment of hypothyroidism. All right, now let's come to the pathogenesis of your goiter. So there was lack of iodine, there was certain goitrogens. All right, now these lead to decrease in production or synthesis of your thyroid hormone. All right, now this leads to excessive TSH stimulation. All right, so this excessive stimulation of TSH leads to cyclic hyperplasia involution. All right, now this leads to a condition called as diffuse goiter. Now this doesn't usually stop here. It leads to repeated hyperplasia plus involution. All right, so there were now if there is, so first stage is diffuse goiter. After that, if it continues, it leads to repeated hyperplasia and involution. So what happens then? What happens then is that there is fibrosis of the involuted areas. All right, and growth of the hyperplastic areas. All right, so there was diffuse goiter, and the complication of diffuse goiter after your repeated hyperplasia and involution leading to fibrosis of the involuted areas, growth of the hyperplastic areas, leads to something called as nodular goiter. All right, now to explain this concept a bit better, I will draw this diagram. All right, let's assume that these are the involuted areas. All right, and this is the hyperplastic areas. All right, so the involuted areas were undergoing fibrosis. All right, so there was fibrosis of the involuted areas and growth of the hyperplastic areas. All right, now, and that cycle continued, which led to your nodular goiter. All right, so now we'll discuss the morphological features of your simple goiter, that is your diffuse goiter. All right, now coming to the gross of your diffuse or simple goiter, we see that there are cysts. All right, colloid filled cysts. All right, and we also see that there is moderate enlargement of the thyroid gland. All right, it weighs around 100 to 150 grams. All right, and if you also see here in the cut surface, all right, we can see some brown gelatinous substances. Okay, so cut surface of the thyroid gland shows brown plus gelatinous substances. All right, so those were the gross features of your simple or diffuse goiter. Now coming to the microscopic features, we see distended colloid follicles. All right, and we see flattened epithelium. All right, also microscopy for your simple or colloid goiter has two stages. All right, two stages. So the first stage being your hypoplastic stage, and the second stage being your involution stage. So what do we see in the hypoplastic stage? This is an early stage, all right, which is characterized by tall columnar follicular epithelium. All right, and papillary enfoldings. Whereas the involution stage occurs after the hypoplastic stage. All right, and this is characterized by large follicles, colloid, and flattened epithelium. Right, and that's what we were seeing here. We were seeing flattened epithelium and colloid distant follicles. Now coming to the nodular goiter. All right, now nodular goiter is usually a complication of your simple or diffuse goiter. As we saw in the pathogenesis, this is usually the end stage of a long-standing simple goiter. All right, and this is characterized by extreme degree of tumor-like enlargement of the thyroid gland, all right, which leads to dysphagia and compression of trachea and esophagus, which leads to choking. All right. Coming to the complications. The complications for your nodular goiter are thyrotoxicosis and plumber's disease. All right. Now we're going to come to the morphological features of your nodular goiter. Starting with the gross features, we see multinodularity, all right? We see multiple nodules, and we also see incomplete encapsulation. We're seeing areas of hemorrhage here, and we also see some scarring, all right? And there are 5, please do note this down, there are 5 cardinal signs grossly for your nodular goiter. Number 1 being fibrous scarring, all right. Number 2, areas of hemorrhage, all right. Calcification. Number 4, cystic degeneration and nodularity. All right, so these are the 5 cardinal signs. All right, we also see that the thyroid gland is asymmetric and extremely enlarged, all right, and it weighs about 100 to 500 grams, all right, which is why we could see that in the clinical features there was dysphagia and the thyroid gland was compressing the esophagus and trachea, which led to the individual choking. All right. Now let's come to the microscopic features. All right, we see calcification here. We're seeing areas of calcification. We also see chronic inflammation. All right, we can see that there's a partial capsule. We are seeing variable sized follicles here. We also see areas of scarring, hemorrhage, and macropapilla. All right, we also see something called as Sanderson's pot stars. All right, so with that we'll be concluding today's class. We have completed the inflammatory conditions of your thyroid gland, and in the next video we'll be discussing thyroid tumors.